Hey guys, how are you? This is your cardiovascular guru, Dr. Akshay Sharma. This is the second video in a three-part series on rheumatic fever. In the first video, we got ourselves acquainted to rheumatic fever and studied its pathogenesis. In this video, we will be seeing pathological, both microscopic and macroscopic aspects of the acute rheumatic fever. So guys, let's get started. We will start with a multiple choice question. A 12-year-old girl was brought to the pediatric emergency with exertional dyspnea. Her symptoms were NYHA class 4. Her electronic medical records reveal that she has been treated for pharyngitis 2 months back and she is taking salicylates for joint pain. On auscultation, she had a pansystolic murmur with third heart sound. She clinically deteriorated and could not be resuscitated. The figure below shows the myocardial biopsy done on autopsy. The structure in the stippled box is Aschoff bodies, Anitschkow cells, McCallum bodies and Aschoff joint cells. So before we answer this question, let's see all the options one by one. Aschoff bodies, also known as Aschoff nodules. These are granulomatous lesions 1 to 2 mm in size. They are pathognomic of acute rheumatic fever. This is very important. They are pathognomic of acute rheumatic fever. So what are these? These are foci of fibrinoid degeneration composed of T lymphocytes, plasma cells and activated macrophages called as Anitschkow cells. So Anitschkow cells is a part of Aschoff bodies. Aschoff bodies in itself is pathognomic of acute rheumatic fever. They are foci of fibrinoid degeneration and they have Anitschkow cells in them. They can be seen in any of the three layers, that is the myocardium, pericardium and the endocardium as well. Myocytes are not present in Aschoff bodies. Mind you guys, there is no role of myocyte in a Aschoff body. And they are not seen in a long-standing rheumatic heart disease. If as a cardiac surgeon, when I operate on rheumatic heart disease patients, when I take out the diseased valves, send it for biopsy, these leaflets, these valves do not have Aschoff bodies. This is pathognomic only of acute rheumatic fever. This is a line diagram, more of pictorial depiction of Aschoff bodies. I took this image from Dr. Harshmohn's textbook of pathology. You can see this whole part. This is a Aschoff body. What all it contains? It contains Aschoff cells. This contains necrotic debris. These are mononuclear cells and these are the Anitschkow cells. So Anitschkow cells is a part of the Aschoff body. So this is a little bit in detail. We have three stages of development of Aschoff bodies. The early stage, that is the exudative or the degenerative stage in which the fibrinoid degeneration occurs. The second one is the proliferative or the granulomatous stage. It is apparent from 4th to 13th week and this is the stage in which we have Anitschkow cells, that is the cardiac histiocytes. Cardiac histiocytes appear in the second, that is the intermediate proliferative or granulomatous stage of Aschoff bodies. And the last one is the healing or the fibrous stage. And this ultimately there is fibrosis of the Aschoff nodule. When we operate on patients with rheumatic heart disease, in case of mitral stenosis, which have calcified thickened valves, these do not have Aschoff bodies because there is already fibrosis of Aschoff nodules. Now the Anitschkow cells. Anitschkow cells we just saw are a part of the Aschoff body and are the cardiac histiocytes. These are also known as caterpillar cells. In a couple of seconds we will see why are they known as caterpillar cells. These are enlarged activated histiocytes or macrophages. What are the cellular characteristics? These have abundant clear cytoplasm, central round or ovoid nuclei, usually they are binucleate. Chromatin is condensed into central, slender and wavy ribbon type of pattern. And the nuclei on longitudinal section, they appear caterpillar-like. See, these are wavy. This is a caterpillar, this is wavy, and this is how it looks like in the longitudinal section. In the cross section, it looks like owl eye. So in cross section, Anitschkow cells appear as owl eye appearance. Now, the other options. We saw two options. One was Aschoff bodies, the other was Anitschkow cells. Now the Aschoff giant cells. Aschoff giant cells are giant multinucleate macrophages, and they are nothing more than a coalition of Anitschkow cells. Few Anitschkow cells, they combine and they form Aschoff giant cells, and they are seen in the Aschoff body. So the Aschoff body is a bigger thing in which we have Aschoff giant cells, we have fibrillar necrosis, we have Anitschkow cells. Now, what are McCallum patches or McCallum plaque or the McCallum triangle? These are irregular thickened area. Mind you, McCallum patch is not a microscopic finding. This is a macroscopic finding. These are irregular thickened areas usually seen in left atrium. And how are they caused? They are caused by the regurgitant jet exacerbating the subendocardial regions. There are some subendocardial regions due to rheumatic fever. The regurgitant jet continuously hits those lesions and they cause a patch formation. That is what we call as a McCallum patch, McCallum plaque, or a McCallum triangle. So let's answer the question now. 12-year-old girl. We'll see the important points. Exertional dyspnea. She has been treated for pharyngitis 2 months back, taking salicylates for joint pain. That is, the patient has joint pain, has exertional dyspnea, has a history of pharyngitis, a pansystolic murmur, that is, the heart is involved. There is an element of carditis as well. She deteriorated and could not be resuscitated. And the biopsy, and this is the question. We have been asked about this stippled box. So what is this? This is a Aschoff body. This one is the Aschoff body, the bigger thing which has Anitschkow cell in itself, giant cells it has, and McCallum bodies. These are macroscopic things. McCallum plaque or McCallum triangle, they are not found in Aschoff cells. So the bigger entity is a Aschoff body in which we have Anitschkow cells, we have Aschoff giant cells as well. So the answer to the question is Aschoff bodies. So now it's time to come out of the microscope. We will see couple of macroscopic things in acute rheumatic fever. Again, let's start with a question. A 15-year-old schoolboy is brought to the orthopedic OPD with the complaints of joint pain and fever. The pain moves from one joint to other within hours and is being prescribed with salicylate, which eventually relieve the pain. However, after a week, the boy again visits the hospital, this time in the emergency room with progressively increasing dyspnea. Detailed history reveals a history of throat infection around 3 to 8 weeks. Auscultation revealed a pansystolic murmur. The echocardiography revealed a valvular pathology, which is the most common heart valve involved in this disease process. So the first question is, in this disease process, that means we have to identify the disease process. What are the indications towards this disease process? Joint pain, 15-year-old, adolescent, fever, joint pain responding to salicylates, increasing dyspnea, a positive history of throat infection 6 to 8 weeks back, and a pansystolic murmur. Again, an element of carditis is there. We have 4 options, standard 4 options of a valvular pathology: aortic, mitral, tricuspid, and pulmonary. Let's see. Previously, in the last video, we saw there are 5 important features of acute rheumatic fever. There is polyarthritis, There is carditis, Sydenham chorea, and two skin lesions, erythema marginatum and subcutaneous nodules. The most common is polyarthritis and carditis. This is the natural course of the disease. There is streptococcal upper respiratory tract infection, acute rheumatic fever. The patient might get a recurrent attack or straight away progress to rheumatic heart disease, followed by heart failure, endocarditis, stroke, and the outcome can be disability, surgery, or death. Three important points in rheumatic heart carditis. All the three layers of the heart, pericardium, myocardium, as well as the endocardium, all three are involved. Therefore, carditis in rheumatic fever is a pancarditis. If we come across a patient, an individual who is not previously affected by the disease process, then the first valvular lesion that comes is mitral regurgitation. Mind you guys, the first lesion in a previously unaffected individual is mitral regurgitation and not mitral stenosis. When there are recurrent episodes of rheumatic fever or a long-standing disease process, slowly ultimately damages the valve, and the patient after long-standing disease has mitral stenosis. So the initial lesion is always mitral regurgitation and acute rheumatic fever. Acute stage you will always find mitral regurgitation and never mitral stenosis. Mitral stenosis is a result of a long-standing disease. So rheumatic carditis, there is inflammation of the endocardium and the valves, followed by fibrinoid necrosis, and vegetations are formed which are known as variceae. These are along the line of the closure. What is the line of the closure in mitral valve? Where the anterior mitral and the posterior mitral leaflets meet at the time of the closure. That is the line of the closure. This is the line of the closure. Endocarditis in various other endocarditis like bacterial or subacute bacterial endocarditis, the location of the vegetations are different. In rheumatic fever, the vegetations are at the line of the closure. So this is the line of the closure. This is the papillary muscle, chordae, and this is the line where the anterior mitral leaflet and the posterior mitral leaflet join together, meet at the time of closure. So this is a very important point to remember. Rheumatic fever, vegetations add along the line of the closure. Now 75% of the patients with acute rheumatic fever, they progress to rheumatic heart disease. This is another very important slide. You need to concentrate. Only 75% progress. Now this is a very frequently asked question, that what is the frequency of the valve involvement? The most common valve involved in rheumatic pathology is mitral. The second most, guys, you need to concentrate here. The second most is not aortic. It's not simply aortic. It is mitral plus aortic. In my 15 years of cardiac surgery practice, I have seen very rarely that only aortic valve is involved. I have gone through so many teaching videos in the internet. All say the most common is mitral followed by aortic. It is not like that. If the question has an option of mitral plus aortic, then the second most common is mitral plus aortic. Isolated aortic rheumatic heart involvement is very rare. I have personally seen just a couple, let's say one or two cases in my 15 years of practice in cardiac surgery. So the most common valve involved is mitral, followed by mitral plus aortic, followed by tricuspid, and then pulmonary. If the question doesn't have the option of mitral plus aortic, then the second most commonly involved valve you can say is aortic. Damage to the tricuspid and the pulmonary valve is not direct. It is due to the increased pulmonary artery pressures. Direct involvement of tricuspid is another rare entity, and that of pulmonary is even rarer. Now, what are the changes in the mitral valve in a long-standing rheumatic heart disease case? All the components of the mitral valve are affected. of the mitral apparatus, we have leaflets, we have chordae tendineae, and we have commissure, and we have papillary muscles. All these are involved. What happens? Leaflets become thick and calcified, commissures get fused, and chordae get shortened, and they ultimately give a picture of fish mouth. This is the fish mouth. So a fish mouth appearance is characteristic of mitral stenosis. This is an echocardiogram. I recently operated this patient. I did a mitral valve replacement in this. This is a fish mouth. This is a seen on echocardiogram. So let's answer the question now. 15-year-old schoolboy comes to the orthopedic OPD with joint pain and fever. The pain moves from one joint to other within hours, that is migratory polyarthritis. Salicylates are prescribed, and these patients tend to respond to salicylates very well. The patient has increasing dyspnea, throat infection, history of throat infection 6 to 8 weeks back, and a pansystolic murmur, that is evidence of involvement of the heart, the evidence of carditis. So which is the most common heart valve involved in this disease process? Now we have identified this disease process is acute rheumatic fever, and we are talking about rheumatic carditis. So the most commonly involved valve is B choice, mitral. I'll again stress upon here, the most common involved valve is mitral, followed by aortic plus mitral. If there is no option, like in this question there is no option of aortic plus mitral, then the second most commonly involved, you will mark it as aortic. So in this video we saw the microscopic and the macroscopic pathology of acute rheumatic fever. This was the second video in the 3-part series on acute rheumatic fever. The link of the first video is given in the description below. The third and the final video will be on the diagnosis of acute rheumatic fever. Till then guys, study hard and stay focused.